1103 416 870 6400 star 640 in cell. Our good pal, Dr. Payne, is back.
I'm your good pal, eh?
What's going on, man?
That's nice. I'm good. How are you?
I'm good.
Let's talk about you.
Yeah.
Let's talk about you. I think it's time.
I think your advice. Your advice at the beginning of the show before the mics went on.
You don't
from the neck down. Good call.
Thanks for sharing with everybody. So tell us what's going on.
I got to
start from the beginning. Let's do this properly.
Well, we think from
no, we don't think anything. Tell me your symptoms before. Pretend like I don't know.
Okay. Numbness in the middle two fingers.
Okay.
Right.
On the right side.
On the right side, yeah. And when I sleep or attempt to sleep, which hasn't been happening lately, lots of pain wakes me up in the middle of the night and numbness. A little bit in the left, but more in the right.
And what about your history of you had a pretty bad disc herniation at one point in your neck, right?
In my neck.
One of the T's?
Yeah.
No, the discs. Yeah.
One of the T vertebrae. I'm not sure which one.
No, it was in your cervical spine.
Was it cervical?
Yeah. Yeah.
And anterior bulge still facing the front.
Yeah.
So they wouldn't do surgery on it.
When that originally happened, did you have symptoms in your arm?
No.
Never.
No, it felt like a really bad trap pull. I thought, I did do it in the gym, but it was just, at that point, it was just right down my back. You know, when you pull a trap doing something, it was really bad. And then, it just kind of went away. I had some atrophy. My right arm got really small, which kind of freaked me out, but then it kind of came back a bit. This is fairly recent.
This is newer, yeah. This has been going on for what, like
a few months at least.
A few months, yeah. And we took a look at it. So I think, and you've been doing treatment, which is good. Yeah, and that's still like a drop of water, right, in an ocean when you consider the long-standing neck pain problems that you've had. So I don't think there's any cause for concern yet. I think you're in good hands in terms of the treatment you're getting. I think you have to continue the treatment. I think we need to realize that when you have injuries like you've had previously, this is where areas of the spine might degenerate quicker. And again, degeneration of the spine is overall insignificant if it's not pushing on anything vital. But if it does degenerate enough that osteophytes form and it, say, pushes a little bit on a nerve and creates these symptoms for you, then yes, it's significant. So I wouldn't be surprised, and I think when I saw you that time, I told you that it probably is a little bit of that going on. Mm-hmm. Also, a little bit of muscular stuff. Like it's usually a combination of things. It's not often one thing or the other. The good stuff is that when I assessed you, there was no hard neurological findings, so nothing that's concrete where we could say, well, the reflex is gone or your power is getting diminished or you're unable to sense. I know you have altered sensation day to day with the things you're doing, but you don't have loss of sensation. It's not like you can still distinguish between sharp and dull. You could feel vibration. Right. And so these are all very important signs, which is good, which means that you're in good hands. And typically these things with treatment could take up to 6 weeks to get better. So again, I think do you feel any better or no nothing at all?
To be realistic, no. I still have the numbness. I still got the pain.
Yeah. So I think what happens at that point, if after about 3 or 4 weeks, you're saying I don't feel better at all, then I think it's time to get an updated MRI of the neck. Okay. And I think that's a good plan of management, and we take a look at it and see what's there. That won't overall change per se how we treat it, but it will essentially help to confirm what we're thinking. And I think that's a big thing, because if we can confirm what we're thinking, even if you're not getting better, we know we're on the right track, or we reassess and consider it could be something else.
I understand the treatment so far for what we think it is as far as the bulging disc is concerned, but you mentioned possible stenosis, right, which is a narrowing of the channel. How do you treat that, or can you?
Yeah, you can treat it.
Get in there with a drill bit and start hacking it out? Like, what do you like?
Yeah, there is absolutely a surgical option for it if it's isolated in an area. Again, you don't have hard neurological findings, so it wouldn't overall make sense to do that, because surgery is very good for function. So if there's a problem with the function of something like the power or the reflex, it's good at restoring function. If it's just a matter of perceived pain, surgery is not often the best answer for those things. A lot of the things around stenosis, we've talked a lot about stenosis in the low back, and we often talk about that, and we don't talk about it as much in the neck, and that's for two reasons. One, because stenosis of the low back is much more common, and And 2, I guess not too many people call with it, so I guess we don't have much. Right. But in your case, a lot of the stenosis treatment, as you know, even with the low back stuff, is mainly around exercise and positions and postures, and how do you essentially keep pressure off of the nerve. So I think plan of management, again, in a few weeks, if you're not feeling any better, we do the MRI, or we could do the MRI anyways. We send you for that and see what we look and we see, but or amputate from the neck down.
Whatever, it's an option. I'll need a smaller chair. Just my head sitting here doing the show.
Exactly.
That'll be cute.
Yeah, so that I think that's a good idea for you.
Yeah, man. We'll take a short break. How about we do that and get into your phone calls? Feel free to call in. We have wide open lines, 416-870-6400, star 640 on cell. Something aliens, you want some questions, basically. Dr. Payne is here until 12. It's Dr. Payne Show, Global News Radio, 640 Toronto. It is 11:11 on the Dr. Payne Show. What else is happening with you, pal?
Yeah, so as a nice segue, we were talking about stenosis in the neck, and I'll move on to a case that I saw this week about stenosis in the low back. So I had a husband and wife, older couple that came to see me, and for a very long time, I think it was something like almost 2 years, the primary symptom has been burning at the bottom of the feet, of both feet. And what's very, very unfortunate in this is that all of the treatment that's been rendered, and there's been a significant amount, has always been towards the feet, and without any solution of the problem. I saw this person after number one, watching them walk into my office. I was already thinking stenosis because the stoop forward posture, without even knowing what they were there for. And then I heard the symptoms of burning feet, primarily with walking and standing, relieved when sitting, and then some other things, previous low back injuries and things like that. And as we went through it, and I said, no one's ever stopped to look at your back for this? And they said, no, I've gone to places, they've given me orthotics, compression stockings, they've done treatment on my feet. Some people have gone as far as to say that it's because the skin on my feet is too sensitive, like all these weird things, and just a complete mismanagement, in all honesty, in my opinion. And we did the physical exam, we checked things out, and obviously without imaging, I'm not able to say with 100% certainty that there's stenosis, but I'm 99% sure that it's stenosis. So, we've given him the recommendations on what to do, but they were both extremely happy with finally having an answer, and they said that they felt, even he's like, it's funny, I've always felt that it's not really my feet. Like, he had some inherent thought or however that just made him think, no, this isn't related to my feet.
Spidey sense is telling me it's not my feet.
Yeah, something was just telling him this isn't my feet, and they were just so happy. I spent a significant amount of time explaining to them what stenosis is, the things they should or should not be doing, the recommendations, and they were just so happy. One of the other things around stenosis, which is a tough conversation to have with people, is the recommendation of a walker when people have some pretty severe stenosis. And as people get older, obviously nobody wants to be told that they need a walker or anything, right? It takes away your independence, and it sort of changes who you are as a person, but there is nothing to be ashamed about. So one of the things that I wanted to get across, and everyone that I speak to about stenosis, especially when they're elderly, is this isn't something that doesn't matter how it looks or what it is. It's going to help you. Could potentially, more than help you, save your life. And the reason why it could potentially save your life is as your posture bends forward naturally, that's not you doing it, that's your body doing it. Your center of mass changes. As your center of mass changes, you're more predisposed to fall wherever your center of mass is. So if your center of mass is falling towards the front of your body, then, with the right force, you can completely fall over. And one of the big risks when in the elderly with mortality is the risk of fracture, especially something like a hip fracture. And so the last thing you want to be doing is getting a hip fracture when it's one of the most fatal things that can happen to someone who's elderly. So number one, it prevents that. It can save your life, and that's extremely important. Number two, as you're walking, so that bent forward posture actually helps to relieve pressure off of the nerve. What people will naturally try to do is, as they bend forward, they want to straighten up. And there's this constant fight between bending and straightening up because you can't really walk, again, if your center of mass is too far forward. What it does do is it allows you to not have that tug of war anymore. You can just go ahead and walk in the posture that feels comfortable for you. Another great thing about it is these walkers often have a little seat on them. One of the big things with stenosis is that after a period of walking, you need to sit down. That opens up those holes where the nerves come out further. That increases some relief. And so that's very important to create that relief. So I really wanted to get that across too, because a lot of people have been coming to see me for spinal stenosis, especially in the low back and in the elderly. And it's a recommendation that I often make, and it is very hard for people to hear. A lot of people sit there and they're either completely against it or they're crying and whatnot, and that's fine. There's nothing wrong with the emotion behind it, but I really want to stress this on, even if you don't come to see me and you know you have spinal stenosis and you're losing sensation in your feet. And that's another big thing, actually, that I should add. It's not just about the center of mass being forward. As the nerve becomes affected, your sensation and proprioception, which is your spatial awareness, become affected. So each step is harder. You may not necessarily know what you're stepping on or not stepping on. And it's very, very important. It could save your life. And I just think that if you've been told that you have spinal stenosis and it's severe, especially and things are progressing, it's not a bad idea. And in fact, this gentleman that I saw, one of the things that he said was, when I asked him when he walks, how he feels, and he said it feels very bad. He said, with the exception when I'm at the grocery store and I have a shopping cart in front of me and I sort of lean on it and I walk, I actually tend to feel pretty good. And I was like, well, there you go. And his only symptom was burning in the feet, right? And this goes back to what we continue to come back to, which is that just because you feel pain somewhere does not mean the source of the pain is necessarily there. It could be somewhere else. It could be anywhere in your body. And so it's very, very important that a trained professional who doesn't just – the problem – I guess the problem is a lot of people, if you have a hammer, everything becomes a nail. So, if you have a foot problem and you're going to a certain specialty, they're going to think that it's a foot problem. And if you're going somewhere else, they may just think it's a spine problem. And I think it's very important that practitioners stay objective and that they're not just worried about, well, what is it that falls within my scope of treatment? And that's what I hope for this to be. But it should really be about, what is the problem? And if it falls in my scope, great, I'll try to help this person. But I'm not going to try to force that diagnosis or not be open to the possibility of other things.
Is stenosis the type of thing, as far as a diagnosis is concerned, that can be made worse by, I did this job for 50 years and that didn't help my stenosis? Or is it just you don't have a choice? If it's your body, it's going to happen?
I think there are some things that do predispose you to it. So we talked about like previous injuries, right? So people that have had disc herniations or fractures, things like that, those areas will degenerate quicker. So that predisposes you to it. Depending on the job, it's repetitive strain sprain. So if you've got a repetitive motion that somehow, and the repetitive strain sprain over time will create more arthritis, more degeneration. So potentially, that's also possible. But a lot of the times it's also just genetic, right? So sometimes people didn't have that type of job or what you would assume, but it doesn't really discriminate. And I think even when we've had Dr. Amendolia, stenosis is consistent around the world, right? It doesn't matter whether you're in a rich nation like Canada or in the third world or somewhere else that's totally different culturally. Stenosis exists, and it affects predominantly older populations because it's a process of wear and tear. Yeah, and we live much longer than we're essentially designed for. Right, so where we might have been designed to live to 40, 45, people are
done.
I'm
3 years done, buddy. It's all over.
People are living into their 80s, 90s, and so of course at that point things will start to break down, and that degenerative process is very much expedited as you get older.
We're going to take a short one. Your phone calls, any questions about this or something personally is affecting you, hey, bring it on. Talk about it. Get some answers anywhere, at least get the conversation started. 416-870-6400 star 640 on cell. Dr. Payne Show, Global News Radio 640 Toronto. It is 11:22. Dr. Payne Show here. Little details about how we can get a hold of you. I know you've got some new stuff coming in the new year.
Yeah.
Well, it is the new year, so
it is the new year. Yeah. Yep. So we're opening up for those of you in the west end of Brampton, north end of Mississauga, and the border with Milton, Georgetown. There's a new clinic at Mississauga Road, just north of Steeles. The address is 75 Montpelier. So it's a full treatment center, walk-in pharmacy. So awesome. All your needs in one place. If you need to get a hold of me and would like to, there's family doctors there accepting new patients as well. So for all your healthcare needs, you give me a call. I can help direct you there. I'll also be there 2 days a week in the mornings doing assessments for convenience for those of you on the West End, and that'll make it a little bit easier instead of seeing me at the Etobicoke office, which is where I do my assessments. And then probably in February, I'll also start being up in our Newmarket clinic. And so,
beauty.
Just to make it easier, but more on all that to come. There's some things that I'm in the works on and can't really say too much till they all go through.
What else is going on with you?
Yeah, so same thing. It was a very busy week with patients. I was off for a few weeks during the holidays, so there was an influx of people that wanted to see me, which is good. Some of the other things that stood out, there was the stenosis case for sure that I wanted to speak about. There was another case. So another thing I guess we should speak about is the PRP injections for knee osteoarthritis. And as I've said before, I wouldn't say, so not everybody that calls me and is interested in it, do I make the recommendation. In fact, I think that I often recommend not to have it versus having it. So, because I really want, like, my big objective is to really match people up with the therapeutic intervention that I think will work for them. So the example is I had a person who has I wouldn't say very, but it was definitely severe arthritis. Okay. The beginning of like stage 4, so like right bone on bone, like they need a knee replacement. There's no questions asked. And they're actually in the process of getting that done, but there's a wait for it. And so, they came in to see me, we looked at it and they said, should I do the PRP injection? And even when we've done the show and we've had Dr. Bragava and Dr. Gordon here and they've reviewed the literature, very good evidence for mild to moderate osteoarthritis with swelling of the knee. This is severe osteoarthritis. Like really the only thing that's going to help is that. He's about, let me remember correctly here, I think 7 months away from the surgery.
Okay.
And he's like, I just want to do something for the next 7 months to just sort of help me. And what I essentially said to him is, the PRP injection could cost, on average, let's call it about $700 or $800.
Okay.
I said, why don't you just take that money and once every 2 weeks, get one of the physios, one of the massage therapists, chiros, doesn't matter, at our office, and just get them to run you through some exercises, some therapy, versus one intervention of a PRP injection. Why don't you have someone just work with you, show you how to strengthen, prehabilitate, all of these things, and that money is going to be much better served. And he was like, yeah, I didn't even think of that. He didn't have extended healthcare insurance, but I basically said, well, if you're willing to spend $800 over here, what's the difference if you spend it there or here, right? It's all, you're willing to spend $800 for whatever the best option is for you over the next 7 months. And what my suggestion is that you work with a professional to do the right things leading up to your surgery. And that'll be good for, potentially 10, 12, 13, 14 treatments, which is plenty between now and then. It's not like he has to be there 3 times a week. It's just really something once every 2 weeks. I recommended you go in, you get a little bit of manual work done, some exercises that are shown to you, we progress them, and it just helps to prehabilitate you before the surgery. And so I think it's a very important thing, and I bring this up because sometimes people come in with a preconceived notion that if they're coming in and they want the PRP injection, that I'm automatically going to say, yep, let's go ahead and do it. And obviously, even after if I had that conversation and this gentleman said, no, I still would like to do the PRP, then we'll go ahead and do the PRP. As long as I don't think it would hurt, then I would never stop it. So I don't think it would have hurt him. It just likely wouldn't have been as beneficial. But again, my objective is not to sell something specific. There's nothing that I'm trying to sell. What I'm trying to do is help people get the right answers to the problems that they're living with. And if I can help you get the right answer to the issue, the injury, the pain, whatever it is that you're dealing with, then the treatment is self-explanatory because treatment lines up with what the diagnosis is. And that's really my job, is what is the best evidence-based answer that I can give you based on the medical research that's available, the scientific literature, and my personal experience on what I see day to day with all of the patients that not only do I see, but, between all of the clinics, we see thousands of patients a month. And so, we have a lot of experience. Even I'm only one person and I don't know everything. So every time I feel like I need to have more information, we hold rounds around certain patients when we have complex cases. I'll go talk to specialists in a certain area if I'm not the specialist in that area, to get a better understanding. And I think that's the best thing. So my objective is not to sell a PRP injection or a brace or orthotics. But if those are the recommendations that I think will be the best thing for you, then that's what I'll make.
Do you find people are lacking when it comes to treatment? They don't want to give it the time that it needs?
Absolutely.
Like
yeah, 100%.
me, for instance, so I just want this neck thing gone, and it's not going anywhere?
Yeah,
it's pissing me off.
Yeah, you're a good example. And one of the analogies that I always use is these things take time. When you're dealing with something that's potentially 10 years old, for example, and you've treated it now over the last 3-4 weeks, you got to be fair with what you're, this has to be a fair fight here. We can't put a lightweight in with a heavyweight. It needs to be equivocal. What we're looking for as practitioners is the right response. So one of the things that I can tell you, even with your case, is you're not saying that you're worse. You're just saying it's not better,
right? Which
is a good thing. And that's where we would be more concerned and expedite things quicker, is if things get worse. Now, I don't like saying that because then people start to overthink it, and you can create a lot of stuff in your head and be like, well, maybe I am worse, but you're not worse. If your initial gut answer is no, I'm not worse, then you're not worse, and that's really what you should stick with. But it is you're very right. A lot of people just are very impatient with this stuff. This is physical type of medicine, and so it takes time for these things to work. This isn't as easy as popping a pill in, which takes 20 seconds. This could potentially be a 45-minute visit with somebody, followed by you having to set aside maybe 20 or 30 minutes every day to do the right exercises, the right things. You need to be cautious about your posture. So there's so many things involved in the treatment of injuries and pain. It's so multimodal that it's time-consuming. And because it's time-consuming, we're creatures that want to minimize how much time we have to spend on anything like that. But it's the trade-off that you make if you want to get better.
416-870-6400, star 640 on cell. Lines open. You got calls, questions about your health, bring them on. Dr. Payne Show rolls on. Global News Radio 640 Toronto. 11:32 and right back at it. Dr. Payne Show. Bart, thank you for hanging on. How are you?
Hi, I'm good, thanks.
Good. What's your concern?
I play hockey, and I injured my elbow about months ago, and it's the pain is purely in my elbow. It's not in the muscles around my elbow. But people have told me I have golfer's elbow. But
are any of those people healthcare professionals?
No.
So then you need
to get into a doctor, but it's been very difficult.
Yeah. So you have to make that time because random people telling you something or using Dr. Google is not the right way to do this. And so step one is figuring out what exactly it is. If it is potentially tendinosis on the lateral side or the medial side, there's a lot of things that could happen in that area. It could be a bursitis, could be a simple ligament strain. You can't just assume that it's golfer's elbow. And then, things like golfer's elbow, tennis elbow, plantar fasciitis, these are very much things that if you don't treat in the beginning when it's early, they often become chronic issues because there's clearly a repetitive sprain presentation that's happening that's aggravating this area, and you need to get it looked at sooner rather than later.
Mm-hmm. Okay, yeah, it's right on the funny bone is where the seams.
Yeah, on the medial side. Yeah, but even then, you again, that's I'm hearing a symptom, but I would need to move your elbow around and do different tests to confirm. It could very well be golfer's elbow. I'm not saying that it's not. I'm just saying that listening to random people give you a diagnosis is not the way to get a diagnosis.
Right.
Yeah.
Just on one other question.
Sure.
When it does, and if it does get better, at what point in time would you return to normal activities? Would the pain have to be gone?
That's a loaded type of question. It very much depends. You return to play or return to an activity should be a gradual reintroduction, and it shouldn't necessarily be when everything is gone in terms of pain. And also, just because your pain is gone doesn't mean that there's not a problem still there, because it can come back. So it's a difficult question to just blanket statement answer, but it should be a transition.
Okay.
Yep.
All right.
Okay.
Well, thank you.
No problem.
Thanks, Bart. Appreciate that. Your calls as well. 416-870-6400, star 640 on your cell. Marilyn, good morning.
Good morning.
How are you?
Pretty good.
Okay. What's your concern?
I had a back operation for spinal stenosis in 2008, I think it was, or 10.
Yep.
And now I can't lift up my left leg. I've had the needles and that, and they came with the conclusion that the spinal stenosis is worse again.
Okay.
Everybody tells me, get out and walk. Well, when I
don't
walk,
listen
I'm
to
in
everybody.
A lot of pain.
Yeah, no, and that's fun.
I'm talking about doctors too. So
no, well, they're wrong. You can't get out and walk if you have spinal stenosis. There's better options like stationary pedals to keep the motion. I think movement is important, but it has to be the right movement. The other thing here is remember, having surgery for spinal stenosis is not an answer. It's sort of like, the best way I can put this is, if someone told you had cardiovascular disease and you had, sclerotic arteries, and they do a bypass surgery, that doesn't mean you can still be unhealthy and do things. It's just a temporary solution for a problem. So there still needs to be exercises that are done even after the surgery. And now we can't go back, and I'm not sure even if you may or may not have done them. But what we do need to realize is not a cure. It's just a management solution. And we're talking about 2008. This is now 11 years later. So stenosis will progress again because it's degeneration of the spine. And one of the things that expedites degeneration is trauma. Surgery is definitely a form of trauma. It's controlled trauma, but nonetheless, It's trauma. And so you will absolutely, after areas of surgery, have more degeneration in that area. So, it was a solution at the time for the time being, but now you're at a point where you need to be doing other things. And most often, these things are best treated with the right types of exercises that should be done and postural intervention. And so this is what I'm helping a lot of people with. And I think you should come see me and get the right answers. But it's funny, you're not the first person that said to me, yeah, people just tell me to get up and go walk it off.
That's the solution for everything.
Yeah, it's like that's what aggravates the problem, and they're telling them to do it, and it makes no sense to me why anybody, especially, I mean, if it was just anybody saying that, that's one thing. But the fact you're saying doctors are saying that, then I'm sort of concerned.
Yeah.
Yeah.
Okay. And what's your name and your phone number?
That would be Dr. Payne. Luigi, you want to write this down? It's 1-855-55 Dr. Lou, DRLU, 1-855-55-DRLOU. Marilyn, or info at paincarecanada.com for email confirmation. David, good morning. How are you?
Oh, I've had better days.
Yeah, I hear you. What's going on, pal?
So I had a workplace injury where I tore my ACL on my right knee, and I was going to the gym before the injury, and the trainer says to me, "Oh, come, you can still come to the gym, just do the upper body." But my knee is killing me, right? So although it's been over a week, the pain is not there as much. I got to be mindful, but I won't be seeing the doctor again until later this month.
So a couple questions for you. So have you had treatment with a physio or a chiro or anybody?
No. He didn't set me up with physio or chiro.
Okay. So you should.
He said that let's see the swelling go down.
Yeah, well, the physios and chiros will help you get that down. So that's number one. That's what you should be doing. Number two, you need to determine if this is something you eventually want surgery for, which, really depends on a lot of things. But part of working out, I mean, if you're going to the gym on your own, I would stay away. You need to understand what it is that you need to do. You could still work out your legs. You just may not be able to do certain things. So one of the things, the ACL prevents your tibia, which is the lower shin bone, from sliding forward on your femur, which is the bigger thigh bone. And that is also a motion that is resisted by the hamstrings. So part of ACL rehabilitation is having very strong hamstrings. So for someone to tell you not to work out the leg, I mean, is just, they clearly don't know what they're talking about. It's just a matter of you need to work out the leg the right way. And in fact, that's beneficial. In fact, there's elite soccer players that don't have ACLs and they just have strong hamstrings.
Really,
and that, and they don't, and they opt to never have the surgery. But I think you should come see me, David, and we can set you up with the right people to get you getting this treated so that you can get back to the things you're doing. And in the meantime, consider if surgery is the right option.
All right.
Okay.
Thanks, David. Appreciate that. Again, 1-855-55 Dr. Lou, DRLOU, and info at paincarecanada.com. I see you there, Mark. Hang on. We'll get to you next. And your phone calls still have time, 416-870-6400, star 640 on cell. Dr. Payne Show, Global News Radio, 640 Toronto. It is 11:42, Dr. Payne Show, 416-870-6400, star 640 on cell. It just takes a minute to call, get some answers, get the ball rolling, if not some mental relief. That's why you want to call in and ask your questions. Mark, thanks for hanging on, pal. How are you?
I'm doing good. How are you guys?
Good. What's going on with you?
So I got this for about 4 or 5 years now. I've had this kind of numbness in my left foot, down by around the third or fourth toe on the left. Mm-hmm. And I thought from years ago, I thought it might be some glass because I stepped on some glass. And I went to the Emerge and they said, don't worry about it. Go follow up with your GP. I've been to my GP. Every time I go to my GP to talk about it, and he feels around. I think it's a Morton's neuroma.
Okay.
He's not sure if it's a Morton's neuroma. I've gone to a traumatologist. They've looked around. They speculate. I still don't know exactly what it is, but it doesn't really cause a lot of pain. Mm-hmm. I've got orthotics for it with the part in there. There's like a bump in the middle of the orthotics. It kind of helps, but I'm kind of annoyed. I'm not really in pain, so no one seems to really...
Have you had any imaging done on it?
Yeah, I have had an X-ray, and it comes up clear. I've said to my doctor about getting an MRI.
What about a nerve conduction? Funny enough, we were just speaking about that with John. Yeah. So EMG nerve conduction studies are very good for identifying nerve issues within the extremities. So that's definitely something that I think probably at this point is warranted. But yeah, more investigation is something that should be seen. The other thing to consider here is, again, the way I started the show. Just because the problem is in the foot doesn't necessarily mean, or because the pain is in the foot, doesn't necessarily mean the problem has to only be in the foot. It could be essentially anywhere else at this point. It could be somewhere in the leg, somewhere in the spine, probably not in the brain because, if it was something in your brain, by now you'd probably know because it would have gotten drastically worse. But still something to consider. So, you need to get it looked at the right way. So I would recommend coming in, see me for that assessment, and then we'll work it up the right way.
Okay, perfect.
Okay.
Thanks, Mark. Okay, thanks, pal. The number 1-855-55-Dr. Lou, DRLOU, and info@paincarecanada.com. I love that whole chain of command, the human body. Figure this out. If it's not this, it's not that. If it's not this, it's not that.
It's the diagnostic process of everything, though, right? It's funny. I had an electrician at my house yesterday doing some stuff, and that's the exact same way an electrician works. They're diagnosing. You're saying, hey, there's a problem here, and by the end of it, there's holes in my basement, and they're, and it's
that
like
you have to fix.
Yeah, well, whatever. But it's the diagnostic workup. Like, I mean, Greg knows with cars, that's what technicians do with cars. It's you're essentially going through an investigative process and ruling things in and out and understanding. And once you understand the machine, whether it's a car, the human body, a house, whatever industry you're in, you can figure out how to figure out what the problem is. And so it's an important thing that the problem is that a lot of practitioners, like, it's not just practitioners, but people, like the things we've heard today where people say, oh, my friends have told me it's this.
Yeah, well.
And it's like, you should not be relying on your friends. You shouldn't be relying on Google. I mean, if you want to talk to people, which, people will always think that they know everything and Google will scare you. But you need to get these things investigated by a professional. And then it needs to be the right professional, because then you get people like that we've talked about that, the problem's in the foot or the pain is in the foot, and that's the only area they bother to look at and not realize that there should be other places that you're investigating. And that's really what we try to do.
It's funny, too, because a lot of people always referred back to their GP, where there's nothing wrong with I got a great GP. He's fantastic. He's a young guy, and he's very knowledgeable. But, I mean, they'll say, my GP says I shouldn't eat more than 2 eggs a week for cholesterol. Yeah, that's not really the case, but you should be talking to a nutritionist, someone who focuses on that type of thing.
And the other thing here is practitioners are unfortunately a byproduct of the era that they were in school. Right? And although you have to do continuing education, you don't do continuing education on everything, right? You might pick the things that, for example, are of a special interest to you, and maybe nutrition isn't one of those special interests. And so you're talking about a doctrine that is 30 years old that has now been updated.
And covered a couple months on.
Yeah, exactly. Yeah. And you're right. There are within the healthcare spectrum, there are specialties that are much more specialized than, just nothing against any doctor, but even me. me. Like I wouldn't be the best person to talk to about diet
or
either.
Crohn's disease.
Yeah,
that's not you.
That's not me. And so you need to be seeing the right people for those recommendations. It's just simply my job to make the patient aware that that's potentially one component that they would need to modify, and then sending them to the right place.
Do you try, how do I put this? Do you favor going to physical rehabilitation manipulation over something mechanical, or it all depends on? Because when I'm with Adrian this week and he's working on my neck, we did acupuncture a couple times. I've had it before in my life. I've never had anything come of it. But when he puts me on the
stem unit,
it's pulling me one way, he's pulling my head the other way.
Oh, right,
we're talking. Even if I haven't felt the benefit of it yet, I'm looking forward to more of that, because I'm always a big fan of get in there, get your hands dirty, and just yank.
Yeah,
that's me, right?
And that's the problem, is that that's what you like, but that doesn't necessarily mean that that's what's necessarily better for you. Now, having said that, if any intervention that you're having doesn't feel like it's having an effect, that is something that should be communicated back to any professional. And so do I favor something over another? No, I think it very much depends. The stage that you're at will determine what the intervention should be. Like, there's some people that will blow a disc acutely, and the first thing you should be doing is taking medication for that. And I'm never one to jump, but if you have a chronic neck issue like you, taking medication probably won't do very much. And obviously in an acute low back sprain or some type of strain or a disc herniation where you're all locked up, you're not going to be able to get that person doing exercises or manually, mechanically do anything to them. So you have to use the best tool at the time. So it depends very much on the scenario. I try not to favor any one thing over another. No.
We'll take a short one. More of your phone calls. Got some time still till just before 12 o'clock. 416-870-6400 star 640 on your cell. It's a Dr. Payne Show on this lovely Saturday morning right here. Global News Radio 640 Toronto. It is 11:51 here. Dr. Payne Show. You want to reach out anytime. 1-855-55 Dr. Lou, DRLOU, and info@paincarecanada.com. It all starts with that phone call. And get in there and get an assessment, at least a consultation.
Start with the phone call.
Start with the phone call, man.
Yeah, just start with the phone call. And I'm happy to have the conversation and just see what's going on. And if I can make the right recommendation simply over the phone, I'll do that. But oftentimes, for specific things, I need to see the person for the assessment.
And I got to hand it to you guys. I mean, when I've talked to Mike or Ange at the clinic, like, you guys are on it, man.
Yeah, we try to be.
Bang, right back. Yep, 1:30. Yep, you're booked. I'm like, wow, simple.
Yeah. We try to run a pretty tight ship. I mean, we're not perfect. Nobody's perfect. We're always looking for feedback. That's the other thing. So anybody that's ever gone to any of the clinics, if there's things that you think could be done better. Like the big thing I think in life is if you're just respectful. Unlike the email that Greg got, right? Like, as long as you're respectful about the feedback, then I think that's the most important thing. And so, let us know. Even with me, even if you're a patient of mine and you've seen me or are going to see me, I'm happy to hear whatever you think after the interaction or before. I'm happy to hear what people think of the show, as long as it's constructive and not rude or belittling or anything like that, then I think it's all fair game.
I think it's fair to say, and this comes from experience of the last couple of weeks working with Adrian at your clinic on my neck, is when you're, especially in your business, when your practitioner says, "Is this helping? Is this doing anything?"
You
don't
need to
lie.
be honest.
You're not going to hurt their feelings. They get it, and I've told Adrian, no, it's not doing. So do something else. Figure it out.
Yeah,
so
and
we'll try this.
Yeah, and it's incredible how many people that I've met that just stopped going somewhere because it didn't work. And it's like, I've even met people that I've seen and they were going to see someone else that works with me, and I say, well, why'd you stop going? Oh, I wasn't feeling better. And when I talk to the practitioner, it's like, but they look at the file. It's like they always reported they were feeling better. And some people, you're right, just don't want to, hurt somebody's feelings. But that's not... When practitioners are asking you, they're asking you because the feedback helps them modify their treatment. Like, you can't possibly know how everybody's going to react to everything. And so, I think you're absolutely right about that. Just be honest. If something is helping, or if you're feeling, like, a lot of people won't say if they're feeling worse. They're coming back and it's like, are you getting better? No, I'm getting better, but really they're getting worse. There's no point in that.
Yeah, why?
I don't know. Yeah. I don't know why people do a lot of things they do. So, but I can imagine that sometimes it's primarily just to not hurt somebody's feelings, right? Like I would assume that's the biggest thing is that they just don't want to insult somebody. But this isn't insulting. No healthcare professional. On the other spectrum, I've heard people say, I told my doctor I went to get a second opinion and they got mad at me. And it's like,
settle down. If
your doctor's getting mad at you for getting a second opinion, we got some big problems here. Okay? We got some big problems. Like you are allowed to get as many opinions, well, within reason that you feel are necessary. And if you're going to see somebody that you feel might be more specialized, I don't think anybody should ever be insulted about that.
And then the offshoot of that is when you tell someone like, I've been 4 or 5 treatments, which isn't a lot. When you
depending like if it's acute, then
10 years, it's not a lot. I get that. I understand that from doing the show long enough with you. And then you tell somebody, I've gone 4 or 5 treatments and nothing's happened. Their reaction, well, you should go see someone else then.
Yeah.
That's right away. Oh, well, maybe he's not your guy.
Yeah.
Really?
Yeah. And again, that may be the case, but I think most people would know. I think the biggest thing is, as long as treatments don't hurt you, like communicating back what it's like. I also think a lot of the treatment process, on the psychological end of things, is how you get along with the person. So I do think you should be getting treatment with someone that you feel like you like right. That you feel like, okay, this is a person I can speak to and be honest with. And if you don't feel that way, that may be what prevents you from telling them the truth, and that could potentially be problematic for you, the patient.
Right.
And so, I think it's very important to not all practitioners. Like I'm sure not everyone that I've treated loves me. In fact, I know some people that have switched over to other people in my office, and they'll tell those people like, "Oh, you're better than Dr. Lou," and that's
whatever.
That's cool. Fine. It's and I've equally had people that have switched to me, and they say I'm better than, but it's not better. It's just that's what works better for you. There's no way to standardize this type of stuff when you're a professional. Even if you're a lawyer and accountant, you're applying your specific touch to it. So there's an art form to it. It's not just all science, and matching up the person with the right practitioner, with the right treatment is really the art of getting this right.
Well, I like dealing with Adrian at your clinic.
Yeah, he said that you guys seem to get along.
Well, because I get to hear the stories about when you guys were in college, so you have no idea what he's telling me, and I know what you did.
I can imagine.
It's the best part of my treatment. Okay, never mind the next. So anyway, when you guys were,
I've got stories about him too.
I bet you do.
Oh yeah, I got some good ones.
You do.
Yeah.
If you guys are all over for sure, and you know what you're doing. Last couple of minutes, advice for people.
Well, a lot of the things that we've talked about today. Number one, don't self-diagnose or have someone who's not a healthcare professional diagnosing you. And if you do have a problem, get it dealt with early. Don't wait. And a lot of people do this, and that's why we tend to get these patients that come in and they say, well, I actually had another patient like this week that said, I've had this shoulder problem previously, but it was always very mild. It would go away within a few days. Mm-hmm. And now it's at the point where it's almost debilitating. It's like, that's what happens. As your body breaks down, that is naturally what will happen. It will get worse and worse and worse. And if you don't fix it, then it's only going to get worse. And it's easy for people to understand that, again, when it comes to a mechanical machine like a car, right? Like if you have a problem with your tires, it's not likely going to get better on its own, right? It will get worse and worse and worse. And that's very much what happens in the human body, is that although the pain might go away, so a lot of people think that pain is the only sign of a dysfunction, but it's not. It's often the end stage of a dysfunction. And pain can come and it can go. And so it's not always good to just simply think, oh, well, the pain's gone, it must all be cured. And that's not the case often. And a lot of these things are management issues, especially when we're dealing with pain and injuries. They don't just these are not things, there's not very many cures. It's really about managing it, and then you minimize the exacerbations when they come back, and you know what to do because you're better educated about it.
Done for another week. Want to reach out, get a hold of Dr. Lou? I suggest you do. I do. You should as well. It's 1-855-55 Lou, DRLOU, and info@paincarecanada.com. Till next time, Dr. Payne Show right here, Global News Radio 640 Toronto.